Good morning. We'll be getting started in a few moments. It's great to see the number of participants growing. We'll give it another probably 60 seconds. All right. Good morning, everyone. I wanted to make sure we got to the number 30, so I think we'll get started now with an introduction. And thank you guys for joining. So my name is Mark Auerbach, and I'm excited to welcome you on behalf of EIIC and the EMS for Children PECC, our Pre-Hospital Pediatric Emergency Care Coordinator Learning Collaborative. So we'll go to the next slide, and I'll just provide some context. I know many of you are familiar with HRSA, but just to reiterate that we'd like to acknowledge HRSA for supporting this learning collaborative under the grant listed there, and that the information or content and conclusions of the speakers today should not be construed as the official position or policy, nor should any endorsements be inferred by HRSA, HHS, or the U.S. government. Next slide, please. So today we are really honored to have some great teams presenting, and we're mixing it up a little bit. For those that have joined the prior communities of practice, the prior sessions have really focused on the initial members of what was called the Learning Collaborative. So those were 9 states that participated in a fairly aggressive timeline in less than 9 months to complete an effort to enhance the number of pre-hospital pediatric emergency care coordinators. And today we'll hear about how one of the non-collaborative states in Colorado, under the leadership of Kathleen Edelgase and others, helped to develop the Colorado Pediatric Emergency Care Coordinator Program. And again, this was parallel and then after the collaborative, and hopefully applying some of the lessons learned from the collaborative as well as some of their own experiences. And then we'll hear from Dr. Julie Leonard, who was a part of the collaborative representing Ohio, in terms of the Ohio EMS for Children PECC, or Pediatric Emergency Care Coordinator efforts, with a specific focus on a web page, and really excited to report that EIIC has been able to work with Ohio to create that web page in a way that other states and other PECC efforts can hopefully leverage a similar architecture to create some of their own initiative. So our agenda today, similar to the prior sessions, is to hear from these 2 team leaders in states, as well as from some PECC's experiences in their state, and it'll be followed by a Q&A. If there's any questions or comments, please feel free to list those in the chat box, and we can go to the next slide. So just as a reminder, the EMSC, or Emergency Medical Services for Children, performance measure for each of our state partnership grants are listed here, and it's that the percentage of EMS agencies in your state or territory with a designated individual or group of individuals who coordinates pediatric emergency care will increase over time. So our goal by 2020 is 30%. By 2023, 60, and then by 2026, 90% of EMS agencies having a group or an individual designated as a pre-hospital pediatric emergency care coordinator, or PECC. Next slide. So what is the PECC community of practice? This is a community where those of us that were involved in the collaborative, as well as individuals that were interested in this topic, but perhaps not involved in that initial collaborative, come together and form as a group with our shared goal of improving pre-hospital care and the shared method of achieving that goal with PECCs, or pediatric emergency care coordinators. And by community, we all share that goal, we all share that same aspirational effort to have the highest quality of care for all children in EMS. And our practice is centered around these quarterly online meetings, but then ongoing interactions. And we've been really excited to see some sharing happening immediately after and in the months between the meetings, and hopefully learning from each other and with each other. So if other states are facing similar challenges, you can apply things that they've already created. The Ohio PECC webpage might be a good example. Or if you're a new state that wasn't a part of the collaborative, you may be able to take some of those experiences in Colorado and address those in your own state. Next slide. So the concept of all of the EMSC, EIIC efforts are to shift from what is termed a learning collaborative, where there's funding and support and infrastructure and a timeline, and the pre-hospital emergency care coordinator collaborative was an example of this, into a community of practice. So shifting from that first group of 9 states to a larger group with a shared interest, and then eventually trying to get to that 90% goal with almost all states and nationally spreading the lessons that we've learned and the resources that we've created. So right now for this collaborative, we have evolved into the community of practice. So this is all come and all teach and all learn, and then hopefully starting to collate the information from all of our different states so that we can create the best resources to support national spread. Next slide. So the learning objectives for today parallel the last session. So we're going to get the experiences of 2 states. We're going to discuss both strategies to address challenges and then some resources that have been created and implemented, and share how you can best utilize those resources for your own state, either in the current form or adapting them. Next slide. And we're really excited to have Dr. Edelgeist joining us today as the first presenter. So she is the Colorado EMS for Children State Partnership Lead. She has extensive experience in pediatric emergency medicine with a board certification, and is a current attending at Children's Hospital of Colorado, where she's a professor of pediatric emergency medicine and serves as the lead of the pre-hospital domain for EIIC as well. She received her BS from University of California, Los Angeles, and her medical degree from University of Minnesota Medical School. And Kathleen was involved as a content expert in the Learning Collaborative and has been able to apply some of the lessons that she learned in her state, who was not a member of the collaborative. So again, really excited to hear how they were able to apply that without the funding and infrastructure that happened in the Learning Collaborative. Next slide. So we'll start out with Kathleen, and then we'll also hear from Robert Weisbaum, who is a pediatric emergency care coordinator, about their experience. So I'll pass this over to Kathleen. Thank you so much, and really excited to see the 54 of you joining us today. And please list questions in the chat box, and if you need this after the presentations today, there will be a recording available on the EIIC website.
Thank you. Can everybody hear me okay? Thumbs up. So I was going to share my screen. Randy, is that still okay?
Yes, you should be able to. If not, I can stop share and it should allow you.
Yeah, I think you have to stop share real quick. Okay, let me go. Okay, I just put some animation in here, so sometimes it's a little bit easier when we're doing that. So I can't see the chat while I'm presenting, so I'm sure other people will be watching, but thank you so much, Mark, for such a nice introduction. And I wanted to just get the opportunity to share kind of what we're doing here in Colorado thus far, where we started, where we currently are, and our current progress. And then we're really honored to have the EMS Fire Chief Robert Weisbaum from Crested Butte, who's one of our participating agencies in Colorado through CoPECC and also through a Target Issues grant that we're doing, kind of speak a little bit to what's going on in Crested Butte. So I just wanted to give a little bit of background about Colorado as a whole, and just to give a sense of like what kind of state we have and some of the challenges inherent in our state. We have about 200 ground ambulance or ground EMS agencies, and we have quite a few number of EMTs, but less than 5,000 paramedics in the state of Colorado, and then a smattering of advanced EMTs and EMT intermediates. The EMT intermediate role is being phased out from the National Registry, and there's been some debate in the state about people losing their scope of practice, which has been a challenge. We are a National Registry state, and our overall population is about 5.5 million. So we have an average of 311 people per EMS provider in the state of Colorado. It's a large state located in the Intermountain West, and our most populous cities are located on what we call the Front Range, which is kind of east of the Rocky Mountains. And therefore, really, to get anywhere as a crow flies seems straightforward, but it usually involves traveling over many mountain passes, depending on where you want to go in any given day, or reaching any corner of the state. And therefore, some of our outreach education and ability is really limited to kind of summer and early fall or late spring, when those mountain passes are safe and easy to travel with. So our state partnership program, we just have a little bit of information here. We're actually housed in the University of Colorado School of Medicine, and we're located on the Anschutz Medical Campus in the city of Aurora, Colorado. I am the program director. Our program manager is Stacy Casada, and we have some family representation. Dr. Angelique Ferriorni, who is also a board certified patient advocate. We have key partners listed here on the slide. It's the Colorado Department of Public Health and Environment, and within that organization or state office, there's the EMTS or Emergency Medicine and Trauma Services branch, and then the Office of Preparedness as well. I've highlighted the RETACs, which are the Regional Emergency Trauma Advisory Councils, and I'll discuss that in a little bit, but they are a key partner, and you'll see why in a minute. We have 3 pediatric facilities in the state of Colorado. We have Children's Hospital Colorado, located in Aurora. We have Rocky Mountain Hospital for Children, and then we have Denver Health and Hospital Authority, which has a small pediatric emergency department and is actually a level 2 pediatric trauma center. Finally, we have our EMS agencies. We are a participating site within PECC, and then we have our state advisory committee, which is our EMS for Children Advisory Council, and that ironically is called a PECC, which often makes this acronym of PECC kind of challenging in Colorado, but that stands for the Pediatric Emergency Care Committee, and it's written in statute and part of our statewide program. So a little bit about the RETACs. Many states have something similar, but the Regional Emergency and Trauma Advisory Councils are written into statute, and they're there to mainly support us a lot of trauma care in the state. There are 11 RETACs in Colorado. You can see how they're spread across the state, and each one has an executive director and a regional medical director. And they are really a key partner. Several of our executive directors are active participants in our EMS for Children program, and we're really fortunate to have their engagement as we move some of our major initiatives forward here in Colorado. So, and I'm sorry if I'm talking kind of fast, but I want to make sure that Julie has enough time to present, and Robert Weisbaum as well. A little bit about our project as a whole. So Colorado's EMS for Children program has several different active initiatives and engagements. And the first I wanted to highlight is COPER, which is our Colorado Pediatric Preparedness for the Emergency Department. And that is essentially our PEDS Ready program, which has been the major focus of our program for the last year. And some lessons learned and things that we're doing in COPER, I think, has been assisting and helping us as we launch our CoPECC program. We're also an EMS affiliate in the PECC, Pediatric Emergency Care Applied Research Network node, and that is our EMS agencies, Aurora Fire, which is in our catchment area, and then a transporting agency, Falck. We're a participant in a targeted issues grant being led by Dr. Cicero out of Yale. And this is to explore the impact of PECS in EMS. And then finally, we do have a very busy, active mobile simulation trailer that has been put on the blocks this last several months because of COVID, but this makes its way around the state and to date has trained over 1,700 EMS professionals, nurses, and physicians in and covered about 56,000 square miles since we launched it in 2014. And then finally, there's CoPECC, which is what we'll spend the bulk of the talk discussing at this point. So Colorado Pediatric Emergency Care Coordinators, CoPECC, we thought it was kind of a nice name that follows along the lines of copper. And I did want to point out our little Colorado Star of Life logo up in the right corner of the slide, just so that you know, our EMS for Children program manager, Stacy Casada, is not only a brilliant public health expert, but she also had an art teacher as a father. So her slides are amazing, and she made some really nice logos for our program, which I'm very grateful for. And we like the fact that we have some nice logos or symbols so that when these projects get launched, people have an image to kind of link to. So the goals of our CoPECC program are to create a statewide program to promote the implementation of pre-hospital PECS. Our work, as we initially conceptualized it, was to create a manual or toolkit for these PECS, support agencies that are implementing PECS by offering resources and training, such as our mobile simulation trailer. There are some other mobile simulation trailer programs in Colorado through other hospital systems that we are also able to leverage as partners. And by 2020, our goal was to have 30% of EMS agencies have a designated PEC, with the goal of by 2023, 60% of our EMS agencies would have a designated PEC. So how are we doing this? So our initial objectives were to work with our RETAC coordinators, our EMS agencies, and other key partners to really define the role of the PEC and responsibilities, and then maximize implementation of PECs at agencies, basically across the region and across the state. So where I've got these little ambulance symbols kind of shows where we are to date. Currently, we're in active engagement with our stakeholders, those RETACs, and through our PEC meetings that happen quarterly, and also through our COPPER program, which meets monthly, as we have a COPPER steering committee. And many of those members of that steering committee are aware that we're really working hard to kind of get a CoPECC program going. We're also, as I mentioned earlier, participating in this targeted issues grant. And we added the quote presence of a PEC to the agency profile at the state. So now when states go in, or EMS agencies go in at the state to kind of update their contact information and other things, there's also a little box that says, do you have a PEC? And I think that this is really key and important because it's bringing forward to the agencies kind of thinking about this before our CoPECC program is really launched in full. So what we've had many meetings where we've engaged with stakeholders, and the messaging of these meetings are shown here. Stacy, our program manager, is kind of imparted that what the PEC does is to the classic definitions: ensure pediatric perspective in EMS protocols, make sure that fellow providers follow pediatric clinical care guidelines, make sure they have the available medications, equipment, and supplies. She talks about promoting education, participation in injury prevention, family-centered care at the EMS agency, and then any pediatric research efforts. And then finally, that they oversee pediatric process improvement efforts, and then liaises with the emergency department. We also have been distributing the infographic created by Rachel Alter for the state partnership programs that kind of show the current status of where we are as a state, and highlights where we're trying to go. So that's kind of the basic engagement that we've done thus far with going around the state and providing being invited to participate in various meetings and then start to talk about this. But I wanted to kind of talk a little bit about the Target Issues Grant participation that we're currently doing. And this is a multi-center project that involves Colorado, Connecticut, and Rhode Island. And the benefit of exploring the role of PECs across these 3 states is that we all have a different model of PECs and EMS. Colorado is a very home rule state, and it's not mandated or required for EMS agencies to have a PEC, unlike Rhode Island, which put it into state statute that EMS agencies are required to have one. And then Connecticut is kind of in the middle. It's a state that doesn't necessarily require PECs, but it did participate in the Learning Collaborative, as did Rhode Island. So Colorado is getting the opportunity to benefit from some of those lessons learned by those 2 other states. There are 3 objectives of that Target Issues grant. One was to develop tools to assess family satisfaction and assess the effectiveness of PECs. The second is to assess actual patient outcomes related to PECs by doing some chart review with a standardized chart review tool. And the third is to assess any change in EMS professional performance and simulation related to PECs. And we're doing this by leveraging our EMS for Children mobile simulator, and then also the ACEP SimBox program, which Mark Auerbach and others have collaborated to develop. And we have conducted a train the trainer for our participating agencies. The agencies shown here are all of those participating in Colorado as part of the Target Issues Grant. And I appreciate your guys' willingness to listen to me talk about the Target Issues Grant, because it is really the lessons learned of this program that we're actively participating in that is informing our future work for PECs. One of the interesting things about our state's engagement in the target issues and the agencies that we are directly working with is that they are all different agencies providing different examples and models of EMS care. So we have Crested Butte Fire Protection District, and you will hear from Robert Weisbaum in just a minute. And that's a rural and tourism-based fire EMS service. I say tourism because this city and region, their population fluctuates over the course of a year between the ski industry and then activities in the summer. And so they have kind of an influx of a variety of different patients and responses depending on the time of year. We also have a county-based EMS service that's located up in Eagle County near Vail. And they serve mainly doing interfacility transports, but also 911 response. We have Colorado Springs Fire Department, which is a very large city fire-based EMS service. We have a rural and frontier fire-based EMS service, Upper Pine Rescue, which is actually down in the southwest corner of Colorado near the city of Durango. And then finally, and that is an agency that also does interact with our tribal communities as well. And then finally, we have a hospital-based EMS service, UC Health EMS, which is based north of Denver and the Denver metro area in Fort Collins, Colorado, at a large hospital, Poudre Valley Hospital. The reason why we chose these 5 agencies and we're so excited that they agreed to participate is, other than the Colorado Springs Fire Department, none of them transport to a children's hospital. So it's very easy for EMS agencies that have a children's hospital in their backyard to be very engaged with pediatric care. But we are trying to demonstrate best practices in working with agencies that don't have a children's hospital next door, and yet we're still able to provide some good pediatric guidance and support to them. So work completed to date on the Target Issues Grant includes that we've identified a PEC for all 5 agencies. We, as mentioned earlier, we've conducted a train the trainer for SimBox training. So this involves the series of videos that are available for kind of a low fidelity out of the off-the-shelf, as Mark Auerbach likes to talk about it, SimBox training. We've provided Preston mannequins to all of the agencies, along with a manual and some books and some training tools and guides. We've established data use agreements for chart review, which is not necessarily easy to do with EMS agencies that are remote from an IRB or a school of medicine. And then we've just published the family tool, which is the family assessment of medical interventions and liaisons with the young in pre-hospital emergency care. And this is the development of a family satisfaction survey that's being conducted among families that have been transported or received care by an EMS agency. And all of our participating agencies in Colorado and throughout the Targeted Issues Grant Program in Connecticut and Rhode Island participated in the development of this tool. And then finally, we are now in the process of doing some focus groups to develop what's called the PECC, or the PECC Effectiveness Evaluation Tool, which the focus groups are serving as a place to generate ideas about what makes a PECC effective. And our agencies are also participating in this. So I'll hand it over to Robert to speak for a few minutes about Crested Butte and what's going on there. Robert, please feel free to unmute and kind of talk about what you guys are doing.
Oh, thank you very much, Doc. Appreciate it. Yeah, so as the PECC here, you know, my job is to try to convince everybody else that's looking into this program that it's not a lot of work. It just takes a little bit of discipline to stay on top of it and making sure that we are kind of following the guidelines and going through these case studies. So as a tourist-driven town, interestingly enough, looking at old data, we have a very high pediatric subset here of approximately 40 to 45%. So we have a big emphasis on doing pediatric education. And going through the SimBox and looking at kind of the setup that's going, it's nice because it trains you to do it in real time. And a lot of times you'll know as educators that when we do scenarios, it's kind of, let's go through it and talk through it while we're doing a scenarios, and it can be extended. So this really focuses on doing it live time and then do kind of an after action review for that. So it's been working out well with us. We definitely do the SimBox on a quarterly basis, but as a whole, we do education for pediatric patients pretty regularly. And that includes daily training with our staff and so on and so forth. So the program's working well. I would encourage anybody that's going to be getting into it is to also add additional charts from QA/QIs that might be interesting. That kind of helps bring back a little bit of a reality to patients that you're seeing versus a scenario. So I found that our crews can better relate to that a little bit more. So overall, I would say it's a very successful program so far. We're happy to be a part of it, and we look forward to continue to improve it. So if you have any questions, feel free to ask me. I can provide any information you want about how it's working for us as a whole, but don't want to tie up any more time for the other presenters. So thank you.
Kathleen, you're muted.
Thank you. I was saying I did see a few questions in the chat. The PECC hasn't been developed for Donna, who asked. So I think our goal is to get that developed and then do a little bit of validation work. But I don't want to speak for Dr. Cicero on kind of his plan on when he'll be launching it. I think the questions that are being asked in the focus groups, they likely can make available, and we'll just follow up with him and get back to you, Donna, about that. And then really quickly on the data use agreements. Well, when we did get IRB approval at the School of Medicine here, and then our kind of School of Medicine and kind of legal at the University of Colorado was able to create almost a memorandum of understanding in this data use agreement. And then we sent those to the agency for their review, also with very specific information about what we wanted access to in terms of their chart reviews. We also verified that particularly for agencies that we're not going to get hospital-based outcomes from, that those charts could be redacted from PHI and protected health information. And that seemed to work out really well. Our turnaround for that took some time. There's a lot of hoops to jump through, but it was really initiated through our School of Medicine. I would say that if you are in Missouri or another state where you're not affiliated with a School of Medicine, your state may have ways to kind of handle some of those data use agreements, but I can't speak purely to that. So our CoPECC progress to date, one is the participation, as I mentioned, in the Target Issues Grant, but we're starting to recruit for our CoPECC Steering Committee. Again, we've got the ongoing engagement with our state stakeholders, including our RETACs, our EMS for Children Advisory Committee, and then our networks through our COPPER program. Upcoming, we plan to participate in the PECC Workforce Quality Collaborative that's being launched through the EIIC. And then, excuse me, we're facilitating our CoPECC Steering Committee meetings to develop some additional program content. But one of the things that we're very fortunate, I know that the states, as you'll hear from Julie and others, you know, they're learning, the Learning Collaborative that was launched, we get to kind of benefit from those lessons learned, but we also get to support our EMS agencies with a checklist and toolkit through the pre-hospital pediatric readiness program, because you know, not only in terms of recruiting PECs and that item being on the checklist, but also giving PECs for these EMS agencies items to support being pediatric ready is, I think, a major component of what their goal, their role should be for the agency. So we're getting the opportunity to kind of benefit from the Peds Ready program in a longer term way. We do long-term plan to not only provide them with information from the Peds Readiness program, but also just support the agencies through some mentorship. And so some of those established agencies like Robert Weisbaum, as you heard from Chris Dubuque, can then mentor other agencies on some of these best practices. We will have some recommendations for the PEC role, skills and qualifications that will likely come out of the PEAT and some other things from our Targeted Issues Grant participation. We are creating a registry and recognition of agencies implementing PECs. We've been able to use some of our EMS for Children funds for our state partnership program to not only create our logo, but have other materials such as challenge coins. And then finally, we plan to have an annual workshop for PECs. This is something Montana has done and other agency or other states have done that have been found to really work well on giving an opportunity for PECs to come together, network, compare notes, and give them some annual training. And it's a little bit of a carrot to the process for recruiting and retaining PECs. I finally, in my last few minutes, wanted to kind of show a little bit of where we were and where we're going in our performance measures, with performance measure 2 being the percent of agencies with a designated PEC, and performance measure 3 specifically looking at how EMS agencies are the processes they're using to demonstrate equipment, a competency with equipment. So our initial assessment done in 2018 showed that about 27% of our agencies had a PEC. A very small sliver of agencies were, quote, planning to have a PEC, and then 45% did not have a PEC, and we had about a quarter who were interested in having a PEC. And what we found just in the last 2 years with Stacy's activism throughout the state and engagement with RETACs is that we're actually making some market changes without much else. So we now have 34% of our EMS agencies who actually have a PEC, and almost 8% of agencies planning to have a PEC. And this is just obviously hot off the presses information. So we're really proud of the progress our state's already starting to see and making in this regard. The activities of those PECs are pretty standard across what we've seen in among other states, where the large majority of them do education and ensure that providers are following those pediatric guidelines if they have them. And then finally, with the majority also ensuring a pediatric perspective and protocols. Not many of our PECs are participating in research, although we have 5 that are in our state. And then some of them are coordinating with our pediatric emergency care coordinator at the hospital level, but not all of our hospitals even have that individual. So that makes it a little bit more challenging. And I think that through our work with the family, we're hoping that we can encourage more agencies to promote that family-centered care. What I think also are larger percent of agencies doing skills checking or having a PEC has resulted in is actually an improvement in performance measure number 3 as well, where we went from about 30% of agencies doing skills checking with a median score of 6 to now almost 40% of agencies. And so we're really happy with the leverage of these PECs are having on meeting our performance measure number 3 in terms of our EMS agencies actually actively participating in learning how to use pediatric equipment for care. So in summary, we have a pretty vibrant program. I think Stacy Casada, I just can't say enough about her hard work. And I feel so fortunate to have her involved and kind of being, 100% EMS for children 100% of the time in everybody's meeting, in everybody's space. It's been a really vital way that our program has kind of moved forward. We are actively participating in that Target Issues grant, and we look forward to leveraging the full CoPECC program soon with those resources I discussed. And then given our current efforts right now, we've started to see some gains, so we're hoping that that will continue. And I will end there and stop sharing. And I'm happy to take questions, but also it's already 9:35, so I wanted to make sure that we could give Julie plenty of time to kind of address what's going on in Ohio, unless Randy or Mark, you want to facilitate anything at all.
No, that was fantastic, Kathleen, and really appreciate it. We'll hear from Julie. Please list questions in the chat box, and I would just implore everyone to consider reaching out directly to the speakers, to Rachel Alter or myself or Randy. Really, the whole idea of this community of practice is about learning and sharing from and with each other. So thank you. Fantastic, fantastic work by the Colorado group. I think really demonstrates how while the community of practice includes both members of the collaborative and non-members of the collaborative, you can certainly not have participated in a learning collaborative and really use the lessons learned as a jumpstart. I think Colorado is a great example of that, and has actually moved past, if we thought about this as sort of milestones, some of the milestones that others in the collaborative have achieved. So fantastic work by your group there. So next we'll hear from the state of Ohio. So Dr. Julie Leonard is an associate professor at Nationwide Children's. She's board certified in pediatric emergency medicine, and she is a lead at the Nationwide Children's Hospital Research Institute, where she's the director of clinical research for the Center for Injury Research and Policy and the associate director for the Center for Pediatric Trauma Research. Over her career, she has been a giant of pediatric emergency medicine through her role in the Pediatric Emergency Care Applied Research Network, and is now in a leadership role with the Ohio State Partnership Program that she'll speak to today. Next slide. And I'll pass it over to Julie and the Ohio team. Thank you.
Great. Thank you, Mark, for the introduction. Randy, if you don't mind turning over the screen sharing, that would be great. All right. Can everybody see my screen okay? I get started here?
Yes, we can.
All right. So I am not going to give an overview of our PECC program in Ohio. Ohio was part of the Learning Collaborative, but instead I'm going to focus today on one of the lessons learned during the Learning Collaborative. And I'm going to talk very pragmatically about a development of a web space to help support our PECs. And I want to introduce also Joe Stack, who is our program manager for our EMSC state partnership grant, and my compatriot in this effort. So crash course on Ohio. So Ohio is the 7th most populous state in the United States, serves 11.7 million persons, and about a quarter of these are children, and a quarter of the population is rural. And strikingly, I mean, we have a very robust medical care capacity within the state. So we have 7 children's hospitals centered throughout the state, and we're serviced by over 1,200 EMS agencies. So unlike Colorado, I was struck by, there being 200 EMS agencies. We, on the other hand, are tasked with having to work and corral 1,200 agencies and help them, and support their PECs. So within these 1,200 agencies, about 8% of transports are for children, but 78% of the agencies servicing the state are rural, and that's our problem. So this is a scatter plot of the data from the last survey in terms of who had PECs and who was thinking about it and who did not. And in green, you can see that our PECs are sort of regionally located throughout the state. And those regions are where our children's hospitals are. And there are very few out in the outlying communities, PECs that were identified. Unfortunately, in Ohio, we don't have a regionalized formal EMS program. So getting communication between our PECs and mobilizing our PECs is a bit of a challenge. And one of the things that we identified was that the need to create a home for PECs where it was sort of one-stop shopping for information. And this led us to think about our current webpage that's part of the Ohio Department of Public Safety. So the challenge with our current state website is that we actually don't have a lot of control over it. It's sort of a very static architecture, and it's very actually difficult to navigate. So you can get to our EMSC programming information, but it's very flat in terms of how we can organize it. It's a challenge in that it's not updated regularly, and this is in most part due to the fact that anything that we post or write has to actually be reviewed and approved at the state level. So if you're trying to be timely in your communications, we have a bottleneck in getting information out. And finally, we're not really able to track activity or our PECs. So it's a public website. Anybody can view the information that's on the website. And so we really don't know, how that web space is being used and whether we're actually, reaching our target audience. And then finally, that website, though not listed here, focuses on our entire portfolio of the EMSC program. And it's not specifically focused on our pre-hospital providers. So we wanted to create a centralized location for Ohio-specific pediatric pre-hospital information. And important to that is that we wanted it to be sustainable. Leadership changes, but we wanted the website to live on. As an example, one option for creating the website would have been for me to create it institutionally at Nationwide Children's, but that would require, always somebody at Nationwide Children's Hospital be available to maintain it. Or another option would be to go out and, seek our own web domain. But again, that's usually tied to an individual. And if that individual moves on, we would, worry that we would not be able to sustain, the website or the web page. So we worked closely with the EIIC to embed a web page on their website, which just recently went live on September 15th. And we've had 58 PECs register to participate on the web page within just this past, short of 2-week time period. So the benefits of having this particular style of web page is that it encourages identification of a PEC. So one of the problems that we have when it comes time to survey our 1,200 agencies is we don't have a really good point of contact of the agencies. And when EMS providers sign up for this web page, it gives us a point of contact with one of these agencies within our state. And so we can easily, track, membership. We actually can update the website or the web page regularly and very easily. There's a administrator interface called Wagtail that's very user friendly, and we have 4 individuals that all have access to that, and rights to continually add information. It also creates a space where members can actually upload documents and information to share, and we'll show you that particular feature. And again, it creates this centralized PECC specific place that we can announce state events and learning opportunities, interesting state news. We have a way to host protocols and also post training resources for our PECs to use. So again, the infrastructure is that the web page is actually housed within the EIIC's website, and it's state specific. So we as the partnership grantees, Joe and I have complete ownership of it, and so can ensure that we're focusing on the needs of our providers within our state. And then again, I mentioned the easy editing software called Wagtail. So the way the website works is that you have to actually request access to it. So it's not open to the public. And so first-time users fill out a form that is requesting access, and then they have to declare information about themselves. So what agency they're affiliated with, the county the agency is located, the number of, the call number of the agency, and their role within the agency. And again, this gives us an opportunity to start to create a directory of information about the individuals around our state that are serving this role. And then once this request is made, then one of our administrators can review, make sure that the individual is indeed an EMS provider and affiliated with an agency, and can grant or deny access. And then once the access is approved, then they have full access to the web page and the web page's resources. And so the membership includes access to basically a grouping of information. So we have an area where we have training resources, an area where we have announcements and direct them to funding opportunities within the state. We have a calendar of events to create a closed group communication. We created a Facebook page, which is linked to the web page. And then finally, an active directory where you can look up other participating PECs. So this is a screenshot of the members only homepage, and with clear linking to the members only sections. This is the landing page if somebody were to go out and search for the web page that they would come to. And it clearly, introduces the idea of this members only space and identifies, the registration process. But we also give a little teaser on this landing page in terms of the availability of the resource library, the news and events section, and then what we call the cruise quarters, which has information about our PECs around the state and the ability to engage through social media. So once a PEC is registered, then they get access to all of the other sections. And so we have an active calendar that is available, and the calendar has basically opportunities that are available throughout the state that are focused on pediatric pre-hospital care. And if the actual calendar event is clicked on, then they get greater detail about the actual event and a link out if they need to register to where they would register. They also can, from this calendar, they can download the activities and add them to their personal calendars. In the news section, it is sort of like a running banner of news where we can do one of two things. We can always post the most recent news at the top of the news section, or you have the capacity to, if something's very important, to pin it to the top and leave it at the top for a longer period of time. Likewise, the ability to use a search bar to actually search for news items. So in this circumstance, as an example, as part of our learning collaborative, we have created these EMS training bundles that agencies can apply for, and that application gives them a set of equipment, including 3 mannequins, and then access to training at each of our children's hospitals. And so we've decided to pin that to the top to encourage people to check it out. Then we have a resource library. So the resource library is where we are going to put all of, sort of our static information from the standpoint of, downloadable documents. So we have a diverse selection of materials that we're providing. Again, we have the actual, documents needed if they're going to apply to funding opportunities. If there's events information like forms that need to be filled out or flyers, we have folders for that. We have folders that provide them pediatric focused EMS literature, background literature about PECs. And then we have a series of simulation plans and skills checklists that are pediatric focused. The resource library is basically linked to a Box account. So right now I'm hosting the Box account for it, and ultimately any of the administrators can have the ability to upload information, and then anybody who is an active member of the web page can download resources. And this is just a screenshot to give you an idea of what the resource library looks like. Then we have the area that we've referred to as cruise quarters. And as I mentioned, it has a directory that's searchable for PEC's contact information. Again, a way, to encourage people to, find collaborators within their regions or their counties that they can work on education with. And then likewise, we have a closed Facebook group that is our means of encouraging active communication and discussion with PECs throughout the state. And then finally, we have a contact page where members can submit resources to share, provide some feedback, or contact web management team with questions. This contact page, they can actually send us a calendar event. They can submit news and announcements to add to our news and announcements section. They can upload, if they have, for instance, model guidelines that they've developed based on our, our recommended state guidelines. They can upload those as a resource to share with other agencies. And, we have another category in case we're not anticipating something. So again, this is a screenshot of the contact page. And again, it's, ability to file upload here as well. And I have to give a shout out to Gab and Annie, who have, been a real help to Joe and I in terms of getting this website up and running. So I am going to stop sharing this particular screen. And in just a minute, I'm going to show you from my view what this website looks like. So this is the overall EIIC website, and I'm signing into my account, but I'm linking out to a request for membership that we had. So I actually, anytime somebody asks for membership, I get an email notification. And so Chris Newsom has identified himself as a EMS provider and a PECC within our catchment area. So I want to know a little more about Chris to see who he's affiliated with. And he's identified his agency idea. He's in Franklin County, and his rank and titles. So I happen to know Chris, so I am going to approve Chris and give him some access. So yes, approve Chris. So this is Wagtail. This is where we actually can build the web page. And so I'm going to just quickly go in here, and it's actually very sort of intuitive. I'm not going to edit anything live or real time here on the webinar, but I'm going to actually go out and view live the actual web page to give you an idea of what it looks like. So this is the members interface. Again, when people log in, they're going to have a banner of current opportunities around the bottom, and then they can go into the members only section here from the landing page. And again, we have, our current calendar of events, our searchable news section, the resource library that allows us to, again, this is a current application that's available to them to apply for a training bundle that they can gain access to. And then ultimately the searchable list of PECs within the state of Ohio. So with that, would be happy to field any questions, about this process. It was rather smooth, and then we were supported by some website designers from the EIC. So I have to also tip my hat to the group there. That was very helpful in us getting this off the ground.
Thank you so much, Julie. So that was really fantastic, and I want to highlight the fact that the concept of the community of practice is continuing on with the great work that the Ohio group had started during the Learning Collaborative. So I really think this is an example of taking the Learning Collaborative and moving forward with it, and not seeing that as the end point, but sort of as an impetus to start this work. I do want to highlight that the infrastructure for that website is something that is through EIC. So if other states are interested, myself or others would be available to chat with people about that process. We do recognize, and I think Julie mentioned it and highlighted it here, that one of the challenges with states' websites is that the flexibility and the ability to adapt creates this model where many states have created their own sites on things like Wix or third-party sites, and then you lack the institutional memory and the ability for this to have some ongoing sustainability. So really fantastic work. We look forward to continuing to learn from Ohio about that experience. I'm just trying to look to see if there were other questions in the chat box that are listed here. I don't see any at this time that are listed. With that, I think if there are additional questions, please feel free to send them to either Rachel, myself, Kathleen, Julie, and we can pass them along to the appropriate people if we are not the appropriate people. But I just want to thank Julie and Rachel and the Colorado and Ohio teams for their fantastic work. And if you are interested or willing to present in a quarterly update, we know that it does take time to put the presentation together, but it hopefully helps us to recognize the work you're doing and learn from you. Please reach out to myself, Rachel, or Kathleen, and we'll coordinate that. And again, the important work that the individuals are doing within this community community of practice is not only those that were involved in the Learning Collaborative, but now has expanded beyond that. And we hope that within the next few years, all 58 states and territories can be engaged in participating in this community of practice for that national spread effort. Thank you, thank you, thank you. Are there any other questions in the last 1 minute here before we close the meeting and wish everyone a good Monday?
I just want to say thank you to everyone for participating. We have a lot of people on the call, so it was really nice to see everybody, their engagement in this. Thank you so much, Mark and Julie, for everything.
All right, so with that, we're right on the hour. Thank you to Kathleen and Julie for keeping us on time as well. That's always a challenge. So please continue all the great work you're doing to advance pediatric emergency care. And please try to do your best to sustain that energy in these challenging times. And we're here for each other and to support each other and to learn from and with each other. And with that, wherever you are, whether it's morning or afternoon, enjoy the rest of your day and be well. And this this content will be posted on the website in the next few days, and we look forward to the next community of practice that some information will be coming out about, probably occurring in early to mid-January. Have a great day. Take care. Bye-bye.